Now the next concept that I'd like to look at here in this system on physiology is HBO in the heart. When we examine the effects under hyperbaric conditions on the particular matters of stroke volume, heart rate, and cardiac output, here's what we find. Under hyperbaric conditions, there is no change in stroke volume. That is to say, if you are ejecting 100 cc's with each beat of the heart, that will not change under hyperbaric conditions. However, the heart rate typically will slow to some degree. This is oftentimes about 10 to 20%. Now, if we have a 10 to 20% decrease in heart rate, what do you suppose happens to cardiac output? Well, of course, it will also decrease. If we decrease the cardiac output, could we decrease the blood pressure? Well, yes, that is possible, but do we? Well, we know that blood pressure remains unaffected. In fact, sometimes it's actually elevated following hyperbaric therapy. It's important to understand that blood pressure is not only a function of cardiac output, but it is also a function of TPR, or total peripheral vascular resistance. Here are the factors that govern the patient's blood pressure: cardiac output and total peripheral vascular resistance. Now, we could apply a different term here and call this afterload. That is the expression of the cardiologist. And if we increase the afterload on a patient who perhaps has a history of heart failure, could this be of concern? Absolutely. So we're going to examine this question of heart failure and the effects of hyperbaric therapy in case management a little later. But that's best covered under the topic of risk factor assessment. So in summary, the blood pressure is unchanged despite the fact that there is a slight decline in the cardiac output because the patients have a marked increase in total peripheral vascular resistance that offsets this and sometimes even results in a slight increase in blood pressure. Now, some of you may be curious to know why this occurs. Well, this is an example of what's called oxygen-induced vasoconstriction. You see, the body always tends to try to auto-regulate substances being delivered. And under hyperbaric conditions, organs are getting so much oxygen that they try to auto-regulate the delivery. For example, the spleen is receiving an abundance of oxygen and recognizes it doesn't need any more, so it sends it somewhere else. It shuts it off to the liver. The liver says, I don't need any more oxygen. It sends it down to the gut. And the net effect is that total vascular tone increases. So again, we will look at the clinical consequence of that later, but right now we want to stay on topic, and that is simply to focus on the physiology. Now, the next area that we look at is metabolic effects. And although there can be several metabolic effects, there's really only one metabolic effect that is important for you to be aware of. HBO has a known hypoglycemic effect for patients with diabetes. And certainly, we recognize that many diabetic patients have problem wounds. Now, the precise mechanism for this was largely a mystery until Dr. Martindale and others demonstrated that the cause or the mechanism of this hypoglycemia is due to an enormous uptake of glucose into the skeletal muscle. This uptake, which can be as much as 50% higher at 2.4 ATA than under normal conditions, is what accounts for this hypoglycemic effect. So all programs worldwide know that they should always check the blood sugars on their patients before going into the hyperbaric chamber. Now, typically, the threshold for that is usually at about 120 milligrams per cent. Some programs may choose other numbers. But the important point here is that these patients must have a buffer. So that as they go in the chamber, if you had a person who came in with, say, a blood sugar of 90, and they were a diabetic with a problem wound, you may say, well, that's great. That's what I'm talking about. However, 90 take away 50 leaves 40. Now you have a patient who is clinically hypoglycemic. So we recognize this as a factor, and it's important that all of your patients has this buffer. Now, I sometimes have techs who tell me, you know, I had a diabetic patient, they went in the chamber, their blood sugar didn't drop. The drop in the sugar is a factor of a number of different considerations. For example, what kind of insulin schedule? What sort of food did they have for breakfast? And when are you seeing the patient? Are you seeing the patient at 8 o'clock, right after they had breakfast? Or are you seeing the patient at 10 o'clock? So it's not so much that every diabetic drops their sugar. What is a correct statement is that every diabetic is at risk to drop their sugar. Again, this is a very important concept because anybody practicing hyperbaric medicine will see a lot of diabetic wounds. And as you'll learn later, the diabetic ulcer is a prominent indication for hyperbaric therapy. Also, it's important to know that the degree or the magnitude of hypoglycemia will depend partially on the way the diabetes is being managed. We know that insulin-dependent diabetics happen to have a more pronounced drop in their sugar than those on oral agents. But all diabetics, be it diet-controlled, oral agents, or insulin, do manifest this phenomena. Now, why normal patients don't manifest this is not really well understood, but nonetheless, the clinical utility remains in recognizing this phenomena. This brings us now to the mechanisms of action. How exactly does hyperbaric medicine work? And I'd like to review for you these mechanisms of action, and then we will round up with a quick review of what the general indications are. The first mechanism of action would, of course, be direct pressure. Whose law is that? Well, that would be Boyle's law. And direct pressure, of course, would have great utility in treating things like cerebral gas embolism and decompression sickness, as both of these are gas disorders. The next mechanism is what we refer to as hyperoxygenation. And at 3 ATA, as you've learned, you will have an arterial PO2 in excess of 2,000 millimeters of mercury. So what exactly can you do with that kind of gas pressure? Well, if you consider the capillary bed of a patient who perhaps has diabetes characterized by malperfusion, somebody with radiation injury with capillary dropout, somebody with a crush injury, a lot of cellular edema, what becomes apparent is that between the capillaries we have these ischemic or hypoxic zones. Now you'll notice here that the normal diffusion distance of oxygen is about 64 microns. That is to say, it is about 10 red cell diameters. Just to give you a sense of scale, a red cell is about 7.5 microns. So we're going about 10 red cell diameters in terms of diffusion. This is inadequate under the conditions that I just mentioned. These watershed or hypoxic zones are left deprived of oxygen. Now, under hyperbaric conditions, as you'll see here, we can push that oxygen out some 250 microns, effectively bridging those ischemic or watershed zones supporting that tissue. Now, as we place a patient in a hyperbaric chamber, we will see an enormous increase in their PO2, as you see here. But it's also true that once we take them out of that chamber, within about 30 minutes, their arterial PO2 will be normal once again. So perhaps a more pertinent question, as far as problem wounds are concerned, is to ask, well, what is the PO2 in the muscle or the skin where the wound actually resides? And what you'll notice on this graph here is that the arterial PO2 is very high, but the PO2 in muscle is not nearly as high. And the same is true for skin. But notice the duration is considerably longer. For the 2 hours in the hyperbaric chamber, one is achieving some 4 to 5 hours of clinically significant hyperoxia. Now this concept here is sometimes referred to as oxygen half-life. That is to say, the half-life of oxygen in any given tissue is really a function of two major factors. One is the blood flow delivering gas to the tissue, and the other is the metabolic consumption of oxygen from the tissue. Each tissue has a unique oxygen half-life. For example, the brain has an abundant flow of blood which rapidly delivers oxygen, but will also rapidly remove oxygen once the gas pressure drops. The brain is also metabolically very active compared to, say, skin. So the oxygen half-life for the brain is relatively short. In contrast, the lens of the eye has one of the longest oxygen half-lives of the body. The lens of the eye, it is essentially avascular, so the delivery of gas is extremely slow. It also has a very low metabolic consumption. So once the lens oxygenates, it tends to remain hyperoxygenated for many, many hours. Muscle and skin are sort of intermediate. So the take-home message, the important concept here, is that your patient may only be in the hyperbaric chamber for, say, 90 minutes or 2 hours, but they are achieving many, many hours of residual benefit after that treatment. Now, the next mechanism of action is that of vasoconstriction. And you may be curious to know why vasoconstriction might be a benefit. The typical magnitude of this constriction has been measured, and it's generally on the range of 25 to 30%. And vasoconstriction can be useful if we're dealing with things like edema. Edema is characteristically found with severe infections or crush injuries. Later we'll examine the concept of failing flaps and grafts, and these too are characterized by edema. And there are two major factors that govern the accumulation and removal of edema. They are oftentimes referred to as Starling forces. The first factor is arterial pressure, that is actually driving the movement of liquid out of the bloodstream. The second factor is oncotic pressure, that is pulling oxygen or pulling fluid back into the bloodstream. Now, under hyperbaric conditions, with this vasoconstrictive effect, we are able to reduce the amount of blood flow into the tissue. Now, this is actually plays to our favor, because by reducing the arterial pressure head pushing fluid out, we are left with a patient that now has an increased absorptive capacity, because there is no change in the oncotic pressure, that is to say the amount of albumin and prealbumin and the proteins that govern oncotic forces. So we're able to mobilize this edema fluid more effectively out of the tissues. It's also notable that despite the fact that oxygen has this vasoconstrictive effect, it is the only known vasoconstrictor that can still simultaneously hyperoxygenate the tissue. Because although there is a decrease in the amount of blood flow coming in, it is more than offset, more than compensated by the enormous content of the oxygen that is present. So the net effect is one of hyperoxygenation. Now let me take a moment here to further expand on this concept of oxygen diffusion. The Crow cylinder model is the classic physiology model that's utilized to understand the delivery of oxygen to tissues. Now in this slide we can see that as you leave a capillary, the farther you go from the capillary, the lower the gas pressure. So in this case, our interest is in the PO2. So as we go farther and farther from the capillary, we notice that the PO2 begins to drop. At some point, that line will intersect with a neighboring capillary. And the sum of these two creates a nadir that's about 40 millimeters, as you see here. Now, watch what happens when we introduce edema. We push these capillaries apart. Consider, for example, a patient that has a crush injury. The foot is run over. The next day you make rounds. It, of course, is swollen. A diabetic with a severe foot infection. The next day it's swollen. And, of course, they've grown no capillaries overnight. And what occurs here is we are separating the capillaries in space. And now these oxygen diffusion gradients go to zero. And you develop these hypoxic zones, these watershed regions between the capillaries. Under hyperbaric conditions, we can push that oxygen much farther, 250 microns, bridging those watershed areas, effectively supporting that tissue.